He is the lead educator in the country. He is currently the head of medical education and the head of global critical care for critical care medicine department at NIH since last year. And prior to that, he was a professor of medicine at the University of Pittsburgh, and then also prior GW at Washington Hospital Center. He trained in clinical effectiveness and evidence-based healthcare at the Harvard School of Public Health and Oxford University, respectively. And throughout his career, his academic focus has been on the education and training of medical students, residents, fellow, both in the US and sub-Saharan Africa. He has received numerous teaching awards, including the Saul Katz Teaching Award for the ACP DC chapter. And he has been the recipient of 2 Golden Apple nominations at Georgetown. He's had various educational leadership roles. He has co-founded the Emergency Critical Care Clinical Officer Training Program in Kenya and is an associate editor for our American Thoracic Society education journal, the ATS Scholar. Of all these roles, his favorite is teaching a class on scientific literacy and numeracy course for the medical students. So today he's going to talk to us about just that. And welcome, Dr. Lee. Thank you.
Okay, well, good afternoon, and thank you for that very kind introduction. Yes, so I have the pleasure of speaking to you about the topic of numeracy. And of all the things that I do, as was just mentioned, it really is my favorite thing to talk about and to teach. So I hope to at least give you some of that enthusiasm for the topic after this. So I want to start with the word numeracy because that's essentially the topic of my talk, but it may not be familiar to everybody. So the word numeracy is very similar to the word literacy, but as you can see, the word literacy is talking about your functional use of the English language, let's say, reading, writing, communicating with words. And numeracy is a similar concept, except it applies to mathematical concepts. And what I need to point out is that we're not talking about like Einsteinian physics or calculus or something very high level. We're talking about like basic things like probabilities, graphs and tables and charts, the things that we see like every day in weather reports or in scientific journals. So I often begin talks like this, and especially if this was in person, I would ask you some silly questions like this, like like raise your hand if you are illiterate, and obviously that is a ridiculous question to ask an audience like this, because it would be literally impossible for you to be illiterate if you were a physician. But if I were to ask you, how many of you are innumerate, that's a different question altogether, because actually the research shows that many physicians are unfortunately innumerate. And so that has, pretty profound implications for science and for medicine and for patient care. So, I think it's pretty common that we talk about math and numeracy, often as a joke. So, here's a newspaper clipping that says that 4 in 10 Americans say that we hate math. And, I think we hear that quite often. But literacy and numeracy are treated differently in our culture. So, for example, there are some occasional reports of like Hollywood celebrities or athletes who are illiterate and they can't read and write, but actually they're quite ashamed of that, and they try to hide it actually, and they try to do something about it so that they're not illiterate. But when it comes to numeracy, I think culturally it's quite acceptable, and actually very highly educated people will frequently say, I can't do math, or I'm not very good with numbers. In fact, during rounds, in the intensive care unit, I would say that phrase, like I hate math, or I'm not very good at math, or I can't do numbers, that comes up, at least once or twice a week, at least in my experience. And so So what I want to, communicate today is that, although that's a cultural phenomena and sometimes it's a joke, and I understand all of that, but actually innumeracy has significant consequences. And there are many academic papers written about innumeracy. Here's a national bestseller about the topic. And then for us as physicians, I want to talk about what the impact of innumeracy could be for our understanding of science, of clinical trials, and especially application of knowledge in medicine. So here's a pretty classic paper from JAMA in 2007, and Windisch et al. Did a study of looking at the common internal medicine journals. So American Journal of Medicine, New England Journal of Medicine, JAMA, BMJ, et cetera. And they took one quarter, January through March of 2005, and they looked at all of the 239 original articles that were published in those 6 journals. And they cataloged, what are the common statistical concepts that are used in these journals? So, and then they just ranked them from frequency. And then they made up a test to assess how well internal medicine residency programs are doing. And so they tested 277 residents in the state of Connecticut. So it includes places like Yale and University of Connecticut, as well as some smaller programs. So I'm going to show you just some of their findings. And so you could probably guess that these are not, necessarily obscure concepts like the meaning of the 95% confidence intervals or Kaplan-Meier curves. These things are all over the papers that we read. But this may surprise some of you, but actually the internal medicine residents scored quite poorly on common understanding of these, or the understanding of these common concepts rather. And now, arguably, for some residencies, maybe this is a little bit less important, but certainly for internal medicine, understanding the literature and having proper interpretation of data is one of our key procedures actually. So this is quite disturbing. So now I want to dig one layer deeper into the concept of numeracy and then illustrate some clinical examples. Now, I'm a pulmonary critical care doctor, so all my clinical examples are going to come from the critical care literature, but obviously these are just examples and they could be applied to any field. So as a way of a transient diversion, I want you to take a look at this picture that's flashed on your screen, and I suspect that some of you may have already seen this, and if you've already seen it, then you shouldn't be saying anything at this moment. But for the rest of you who've not seen this before, I'd like you to take a look at it and try to describe in your mind what you see. This is by Zoom, so it'd be hard to communicate, obviously. So I'm just going to ask you to say to yourself, what is it that you see? And if you stare at it, I think most people figure out that this looks like a piece of bread. And in fact, that's exactly what this is. This is actually a cheese sandwich made by a woman named Diana Doozer from Florida, as you can see. And she basically made herself a cheese sandwich for lunch. She was hungry. And in fact, you can see this bite mark here at the bottom because she took a bite out of it. And then after the bite, she looked at the sandwich further, and she noticed in the middle of the sandwich is what looks like a face. And so she stopped eating it and thought that, wow, that looks like a picture of the Virgin Mary. And so now, if you look at this this picture yourself, even if you didn't notice it in the beginning, now that I told you that there's a face in here, I think everybody is going to see the face. And in fact, it's quite, full of detail, so that you could actually guess what type of picture it is, whether it's a man's face or a woman's face. You could even speculate about the ethnic background or the race of this face. You could guess the approximate age. You could even guess the hair color. It's quite amazing of how much detail is actually found here. So then you might ask yourself, what does one do when you see the picture of Virgin Mary in your lunch? Well, at least for Diana Doozer, she decided to sell this actually on eBay. And this sandwich actually sold apparently for $28,000. Now, the reason why I'm telling you this, this story is not for its entertainment value, really, but it's actually a very common human tendency that we all have. And if I give you a slightly different example, when we were children, especially because we had more time, we might be looking up at the sky, and then we would see random cloud formations, basically water molecules, and we would see certain patterns. So, so without much effort, I think most of us, when we see this cloud formation, we would see what looks like a galloping horse. So here's the head here, and then here are the front legs, some back legs, and then maybe a tail over here. So what this refers to is a concept called apophenia, and it's a fancy term, but all that really means is it's a natural human tendency to attribute meaning when there isn't one, and a natural human tendency to see patterns when things are actually quite random. So in other words, these are just burn marks on a piece of toast, and the random markings suggest, because of the way we view things, this face. And so it's just called apophenia. And because it's a human tendency, all of us are likely to do this. Now, that's all fine, except when it comes to scientific literature, we're going to have the same tendency for apophenia. So when we see articles in the New England Journal of Medicine or JAMA, and we see things like p-values here is 0.03, or this confidence interval that does not touch 1.0, we're going to interpret that as a particular meaning to us when it may just be a random phenomenon. So of course, that's what statistics is all about, is to try to differentiate randomness from pattern. So let's get to some clinical examples. So here is a paper by Wenzel. It's a pretty well-known paper. It's a randomized controlled trial of approximately 1,200 patients, as you can see here, vasopressin group here, epinephrine group here. And then they're reporting their main findings on this table 3. So here is all patients, VF, PEA, asystole. They're basically studying, does vasopressin do anything better than epinephrine for patients in cardiac arrest? You can see multiple p-values reported here. So I'd like you to just pause for a second and just kind of, maybe in your own mind, commit how this paper would be interpreted by, let's say, a typical physician versus maybe a more numerate physician. So, so in this particular case, the conclusion of the paper was that vasopressin was not superior to epinephrine in all patients, but however, for those with asystole, vasopressin had a significant benefit compared to epinephrine. And it is because of these p-values here of 0.02 and 0.04, especially in regard to hospital admissions and hospital discharge. So, I'm going to just use a very silly example, because I think for the majority of you, this is not a necessary example, but I think it's such an important concept, it's worth illustrating to make sure that every single person is on board. So the silly example is going to be through this couple of gambles, and the gambles are very, very simple. We're going to gamble with a 20-sided dice, as you can see pictured here. And it's very simple. Like I said, you're going to roll the dice, and if it lands on a 20, you lose this bet. If it lands on anything else, 1 through 19, you win. And let's say we're going to bet $100 from this gamble. So just a quick reminder for your test of numeracy, essentially, is let's be clear on the probability of winning. Well, you're going to win if it lands on anything 1 through 19. You're going to lose if it lands on 20. So hopefully it's not too hard to figure out, but you would agree that the probability of winning is on your side if you're going to enter this bet with me. And the probability of winning should be 95% or 19 out of 20 possibilities. And if you know that, of course, the probability of losing is the remainder, which is 1 out of 20 or 5%. And of course, I'm choosing 5% because that's the common threshold that we as a society have accepted for p-values for statistical significance. So if you enter this bet, overwhelmingly, you are going to win the $100 because you have a 95% chance of winning and only 5% chance of losing. Now comes the ridiculous example that I hope to illustrate this point, is that after you and I agree on this bet, let's say this is what I show you, and then I say, well, it looks like there's a 20 here, and so therefore you lose because the bet was if you roll a 20, you lose, and otherwise you win. And then I would ask you to pay me the $100. And I know that all of you would immediately object because that's not what you were expecting. Obviously, you were expecting for us to be having only one dice in this bet, and so therefore only one roll. But what I did here, of course, is I roll the dice multiple times. In this case, looks like 10 times. And if I keep rolling, then eventually a 20 would be rolled. So this is not a difficult concept. This is called multiple testing, which simply means that more times you do a p-value test, then just by chance, something that is random is going to appear to be quote unquote statistically significant. So a very common problem. So then if you insert that back into this paper by Wenzel, essentially, this portion of the table that I'm showing you, there are 12 different p-values here. And so if you roll the dice 12 times, then just by random chance, even if there was no difference, you're going to find occasionally some p-values that look quote unquote significant. Now, despite that, of course, the conclusion of the paper was that vasopressin was superior to epinephrine in patients with asystole. So here's an accompanying editorial in the same issue of the New England Journal of Medicine. And Dr. McIntyre here writes that because of the size and the power of the study by Wenzel et al., practitioners should perhaps be encouraged to incorporate the use of vasopressin into their resuscitation protocol immediately. And he goes on to say that the American Heart Association and the American College of Cardiology should convene in order to issue an interim guideline incorporating these important new therapeutic advances. Now, if indeed this was just randomness and it was just apophenia that caused the authors and this editorial a comment to be made, then if you were to repeat this exact same study, the role of vasopressin versus epinephrine, then the next time around, the findings would not be duplicated. And indeed, that's exactly what happens here, is that when they repeat the study and now publish only 4 years later, they could not replicate the findings, which is what you would expect if it was all randomness. So essentially what I'm telling you is, to some of your surprise perhaps, but actually New England Journal of Medicine is in the business sometimes of selling you $28,000 cheese sandwiches. So let me show you one other ridiculous gamble just to make another point that is quite similar. So let's say now you're going to enter the same kind of gamble with me, and you are now more numerate and you are now more sophisticated. So you're going to insist on the fact that that there be only one roll, okay, to avoid this problem of multiple testing. And then you're going to go take one step further. You're going to say, you know what, we're going to declare on a website by pre-registering this bet to say that 20 is the bet, is the outcome that we're looking for to actually determine whether you win or lose. Okay, so I cannot, I cannot change that outcome. So I agree to it, and you now enter the bet again, hoping for that 5% risk of losing again. So here's what I show you now. Okay, so I show you this, and I say this is the result of our bet, and so it looks like now you owe me $100 again. So I'm showing you one roll, but what you'll notice is that I'm not showing you the entire field like I had shown you last time. In other words, what I had really done was really done multiple testing. In this case, I rolled it 5 times, but I'm choosing to show you just one of the outcomes. And so this is a pretty classic example of what is known as publication bias. That is, in this case, I've done 5 randomized controlled trials, but I'm only publishing one of them. So as far as you're concerned, it looks like it was a huge success, when in reality, it may just have been, again, apophenia. Now you might think, well, again, these are pretty silly examples, and is this really relevant to what we do? Well, I think probably one of the more famous examples is actually with oseltamivir or Tamiflu. So here's a Cochrane review from 2015 that looked at 20 trials that were conducted using oseltamivir versus control in patients with influenza. So, so in this Cochrane review, what they report is that there were 20 RCTs, but only 2 of them were published. And now you might guess as to why those 2 were published. And the reason, of course, is that those 2 were the studies that were the only 2 that actually showed favor for oseltamivir. The other 18 did not. And in fact, the largest trials for oseltamivir were not the ones that were published, even though they were negative. So what they conclude in their Cochrane review is that these drugs as a class may shorten the duration of symptoms by about a half a day or so, but without significantly impacting the number of hospitalizations or more serious clinical outcomes, such as death. And at least what I find is that many physicians are not even aware of this kind of publication bias that may exist for oseltamivir. So here is a lay journal, the Atlantic magazine, that actually talks about this, and they write here that it has the U.S. wasted $1.5 billion on an ineffective drug. And then here's a similar article from the BBC where they're quoting a professor of evidence-based medicine from Oxford, Dr. Hennigan, and he writes, I think the whole 500 million pounds, that's the amount that was used in the UK per year, has not benefited human health in any way, and we may have harmed people. So I'd like to take you to another example. When I'm rounding in the ICU, obviously Tamiflu, that topic comes up, although maybe not so much this year because of COVID, but in a typical ICU week in other years. Another topic that comes up is this issue of norepinephrine. So the article that's often discussed or quoted is this article by De Backer, and this is a randomized controlled trial that compares dopamine versus norepinephrine in patients with hypotensive shock. So, and this is their primary finding. This is a forest plot of all patients. on this confidence interval here. Norepinephrine better on the left side, dopamine better on the right side, 1.0 or no difference here in the middle. And then again, just like I had asked you to think about the Wenzel paper, is for you to think about, what would a typical physician conclude, and what should a numerate physician conclude by looking at this primary finding here. So what was concluded in this particular paper by De Backer is that overall there was no difference in outcome, as you can see from here, with all patients. But they concluded that for patients with cardiogenic shock here, that there was a higher risk of death from dopamine, and that norepinephrine should be used because of mortality reasons for those who are in cardiogenic shock. Now, we're looking at subgroups again. So here is a paper by Wallach that looks at, how should subgroups be looked at in randomized controlled trials. So their objective in this paper in 2017 was they want to know how often RCTs are actually conducting the subgroup analysis, and how often their claims are actually supported by their own evidence. And they're looking at a test called a p-value for interaction, which we'll talk about. So in this paper, what they found are the following things. Number one, they found that of these RCTs that have subgroup analysis, a minority of subgroup claims are actually supported by their own data, that is, by their test of significance in terms of the test of interaction. So only 39% of these trials, actually their findings are supported by their own data. And then they go on further to say that most of these RCTs fail to meet other best practices for subgroups, such as pre-specifying which subgroups you're going to look at, stratified randomization, and adjustment for multiple testing. So here are the percentages. 28% of the RCTs had the subgroups pre-specified, 35% did stratified randomization, and only 2% actually adjusted for multiple testing. Then they note that in some cases, these subgroup claims were then retested in subsequent RCTs. It didn't happen very often, but happened 5 times. But this says when done, these initially observed subgroup differences are not reproduced. So 0 out of 5 cases where these subgroup claims were made, were they able to actually verify the findings in a subsequent trial. So if you go back to the Wenzel paper here, we already pointed out that it could not be replicated. And if you look at the criteria outlined by Wallach, none of the standard good practices was done, including it not being pre-specified, no stratification at randomization, and not corrected for multiple testing, and then no test for interaction or for heterogeneity. So I want to look at this test for interaction and heterogeneity a little bit further. So here's a paper by Wang in the New England Journal of 2007, summarizing how to look at these subgroups in more careful detail. So here I'm gonna just summarize their paper by showing you 3 different examples. So here's example 1. Here's study 1. And the important thing here is to note that whatever the treatment was, it was already shown to be better than control. So the p-value for their main outcome was less than 0.05, and in this case had a relative risk of 0.75, symbolized by this vertical line. So overall, the treatment was better than control. Then they're giving you an example of subgroups. So even though the treatment was better for the whole patient population, now they're dividing into the men versus the women, and then showing you here that men had a p-value for treatment of 0.01, women of 0.72. And again, I would ask you to think about how might a typical physician interpret this value or this finding versus a more numerate physician. So here, you might be tempted to say, well, it looks like the treatment works for men because it does not touch 1.0, this confidence interval, but for women, because it touches the confidence interval of 1.0, that it looks like it works for men, but not for women. Well, as you probably know, well, that's not how you should be looking at this. So the first thing we talked about is this p-value of less than 0.05, which simply says that treatment is different from control. In this case, treatment is superior to control in terms of this outcome. But to decide whether men and women are different in terms of this effect, what you should be focusing on is the p-value for heterogeneity. In this case, which is 0.95, and what that really says is that actually men and women are statistically behaving similarly as far as this outcome goes, so you cannot make that claim. So if I give you another example, here is where, once again, overall finding is the treatment is better than control with a p-value of less than 0.05. And this time, this is the relative risk over here by this vertical line. And once again, the men are over here, women are over here. And you might also conclude mistakenly that this treatment works for men, but not for women. But once again, the focus should be on p-value for heterogeneity or p-value for interaction, which tells us that from a statistical point of view, the results don't show much difference between men and women. And then here's the final example where, once again, the treatment is better than control with a p-value of less than 0.05. And just like before, the men does not touch the 1.0, the women overlaps with 1.0. However, in this particular case, the p-value for heterogeneity, which is simply asking not whether treatment is better than control, but it's simply asking, are men behaving differently than women as far as this particular treatment? And here is where there is a statistical difference. So in other words, if you summarize these three situations, these first two, to many people, is going to look like that men benefit and women do not benefit for situation 1 and situation 2. However, these are just examples of apophenia. On the other hand, this is the one where, because the men and women are behaving differently, that there is interaction, that there appears to be heterogeneity, this is the one that we should perhaps pay closer attention and then use that as a hypothesis generation for further study that could be tested in a new randomized controlled trial. So if you take this principle back to the DeBacker example that we just talked about, this is the norepinephrine versus dopamine, okay? Remember, once again, for all patients, it was not statistically different between norepinephrine and dopamine. But then the next question is cardiogenic shock behaving differently from hypovolemic shock and septic shock? And now what you want to focus on is this p-value for interaction. So their own paper by DeBacker says that p-value for interaction was not significant, again suggesting that hypovolemic, cardiogenic, and septic shock are all behaving similarly, and they're not behaving in a unique fashion. Okay. Now, sometimes this p-value for interaction is explicitly given, like in this case, but sometimes it is not. And there's actually a very quick and easy test that you can do, which is simply to run a vertical line from the mean for all groups. So here at this point, if you draw a vertical line, and simply by eyeballing, does each of the subgroups confidence interval, does this vertical line go through the confidence interval, then you can pretty much guess that, qualitatively speaking, that these three subgroups are behaving statistically similar to one another, even if you don't have a quantitative p-value like you do in this case. Nevertheless, in this situation, DeBacker actually tells you that the p-value was not significant, that they're all behaving differently. However, of course, in their paper, they conclude that there is a concern here and that there is an increased rate of death in this subgroup of patients with cardiogenic shock. And many review papers and actually societal guidelines incorporate this finding, even though it is not supported by the original paper. So again, New England Journal of Medicine is at risk of selling you $28,000 cheese sandwiches. So I'll give you one final example. This happened more recently in the ICU, where a patient was receiving intravenous bicarbonate. And the article that became the topic of discussion is the Bicar ICU trial in Lancet. And so what they conclude here is that sodium bicarbonate had no effect on the primary composite outcome. So here is, again, on the left side, this favors sodium bicarbonate. On the right side, it favors the control group, with no difference being this vertical line of 0. And all patients are over here. So then if you look at this, this is the p-value for overall effect, which was not significant. So I would agree with their primary conclusion that sodium bicarbonate had no effect on the primary composite outcome. But as you can see in their conclusion, they also go on to say the sodium bicarbonate decreased the primary composite outcome and day 28 mortality in a priori defined stratum of patients with acute kidney injury. Okay, so here is the acute kidney injury score. So what they're saying is, of course, is that for those who have more severe kidney injury, that is a score of 2 to 3, looks like sodium bicarbonate favored. The outcome was improved in sodium bicarbonate treatment, as opposed to those with a lower kidney injury score. It did not seem to have much difference. So as we've been talking about, before you can conclude that, you need to look at the p-value for interaction, or p-value for heterogeneity, which is conveniently given here in this Lancet paper. So if you look, p-value for heterogeneity is 0.022. So it sounds like they made the correct conclusion that indeed, that there is a difference between those two. So maybe this is a real finding, and maybe this is something that we should take more seriously. The only problem with this is that if you look at this subgroup here for less than 65 and greater than 65, they claim that p-value for heterogeneity is also very low, 0.003. But any just simple eyeball test says that these two curves for age look very, very similar. And then in fact, if you remember, you can do a quick and dirty test by drawing a vertical line through all patients, and then quickly decide, are these subgroups behaving statistically different from one another? And my quick and dirty test says, it looks like they're all behaving statistically in a similar fashion. So then if you actually plug in these values, this 39, 79, 30, 72, and so forth, so these 8 numbers into any standard statistical software, what's shocking is that actually the p-value is not calculated correctly. This is not 0.21, but 0.81. That doesn't change the interpretation, but it turns out, as you might expect from these two graphs, this is not 0.003. When you recalculate it, it's actually 0.89, which makes more sense given the patterns that you see here. And indeed, this 0.0226 is also incorrect. It's actually 0.11, as suggested by my quick and dirty test. So once again, even the Lancet paper is trying to sell us $28,000 cheese sandwiches. So this is my last slide, and I want to finish with this painting, and I'd like you to maybe just think a little bit about what this painting is about. And I think those of you who are art enthusiasts or have taken art history classes or just in general interested in the topic will recognize this. It's a pretty famous painting. It's done by, I believe, Raphael during the Renaissance. And it's showing a painting of ancient Greece. And this is the painting of the Academy at Athens. And in the middle are two central figures who are surrounded by a whole bunch of other people. And this person on the left of the two central figures, he looks older, and the person on the right looks younger. And the person who's older is actually Plato, and the person on the right is Aristotle. And the rest of these people are other students or other disciples in the academy. Now, I'm showing you this picture because the academy at Athens is sort of the forerunner of the modern university. You know, this is where like great intellectual discussions happen. A lot of teaching has happened, and people are being taught all kinds of important concepts, ranging from literature to biology and mathematics. The reason why I like to conclude with this painting is because supposedly there hung a sign at the entryway to this ancient university, if you will. And I wonder if anybody knows what that saying was on the doorway to this university. Well, it turns out the quote is as follows. It says that let no one ignorant of mathematics enter here. And I like to finish with this is because I think in some ways, I'm half joking, but I'm also half serious. I actually think that this sign needs to hang in front of every single medical school and every single teaching hospital, because I would have a hard time thinking that you could have a physician who is in Numerate, who is graduating, and yet that person can function as an expert in the field and make expert decisions on behalf of patients if you cannot understand the literature that you're reading. So it's a strong statement, I realize, but it's a sentiment that I've developed over the years, and it's another way to say this, of course, is just simply that I hope that none of our graduates from Georgetown or NIH or Hospital Center or wherever you are, we hope that none of our graduates will become peddlers of the $28,000 cheese sandwiches.